Using antibiotics appropriately is important for patient safety and safeguarding against antimicrobial resistant infections. This film will be based on Public Health England's Start Smart, Then Focus Antimicrobial Stewardship Toolkit and the National Institute for Health and Care Excellence, or NICE, Guidance on Antimicrobial Stewardship. When a patient presents with a suspected bacterial infection, a comprehensive clinical assessment and appropriate physical examination must be carried out to confirm the presenting complaint. It is important to establish the likelihood of infection and the related pathogen if possible, supported by appropriate diagnostic aids including early warning scores, biomarkers, full blood count, microbiology testing and radiology. Where there is an absence of convincing evidence of bacterial infection and the patient is clinically stable, antibiotics may be withheld pending the results of investigations. If a patient has signs and symptoms of being systemically unwell or has a high risk of complications, consider using a national early deterioration score such as NEWS2. NICE advised that people with suspected sepsis in acute hospital settings and at least one of the criteria indicating high risk of severe illness or death must have an immediate review by a senior clinical decision maker and antibiotics given within 1 hour if indicated. When a decision has been made to prescribe antibiotics, the following must be done. Consider the severity of existing medical conditions that may lead to dose alterations such as renal or hepatic disease. Consider previous colonization or infection with resistant pathogens such as MRSA or ESBL, recent antimicrobial exposure, recent occupational or travel exposure. A second or third line treatment may be indicated for resistant pathogens. Seek expert advice if unsure. Establish the risk of an adverse reaction to antibiotics. Consider allergy, contraindications including pregnancy, side effects exacerbated by comorbidity or organ dysfunction, drug interactions, and risk of opportunistic infection. Be aware of the risk of Clostridium difficile infection in vulnerable groups such as the over 65s. C. difficile is associated with exposure to broad-spectrum antibiotics, commonly referred to as the 4 Cs. Each trust will have their own specific antibiotic guidelines based on pathogen epidemiology, local antibiotic susceptibility, drug penetration to the site of infection, and clinical trial data. An antimicrobial stewardship pharmacist or medical microbiologist will be able to discuss these further. When choosing antibiotics, obtain cultures where appropriate before commencing therapy. Restrict the use of broad-spectrum antibiotics to patients at high risk of mortality or resistant to first-line narrower-spectrum agents. Indiscriminate use of broad-spectrum antibiotics drives resistance to these life-saving drugs. Control the source of infection wherever possible, for example by incision and drainage of abscesses or removal of infected plastic or metalwork to improve clinical outcomes. Always document the antibiotic plan in the medical notes and prescription chart. This should include the diagnosis, name of the drug, intended duration, and route and site of administration, and date of review. When prescribing antibiotics with a narrow therapeutic range, such as aminoglycosides or glycopeptides, prescribers must follow local guidelines and take blood samples at appropriate times for therapeutic drug monitoring. The dose may need to be adjusted accordingly to prevent toxicity and ensure efficacy. It is critical to record the time of blood sampling to safeguard accurate interpretation of the result. Before certain operations, a single dose of IV antibiotics will be administered within 60 minutes prior to knife to skin. The choice of antibiotic will be determined by local hospital policy. A second dose is required to reduce risk of surgical site infection when the length of the operation exceeds 2 half-lives of the antimicrobial, or the patient has lost blood greater than 1,500 milliliters in adults or greater than 25 milliliters per kilogram in children. A post-surgery antibiotic course may be required where there has been gross contamination during surgery or for pre-existing infected wounds. Review all patients on antibiotics frequently during first 72 hours. Patients on IV antibiotics should be reviewed at least once daily. At 48 to 72 hours, the antibiotic plan and the clinical diagnosis should be reviewed according to clinical response, biomarkers, and results of diagnostic tests and imaging. 5 antimicrobial prescribing decisions can be made. Stop antibiotics if there is no evidence of an infection. It is not necessary to finish the course. Switch antibiotics from intravenous to oral promptly when the patient is responding and can tolerate and absorb oral antibiotics. Change antibiotics to a pathogen-directed therapy according to culture and clinical response. De-escalate to narrower spectrum pathogen-directed therapy, if possible, to preserve effectiveness of broad-spectrum agents. It is not necessary to finish the course of a broad-spectrum agent if switching to narrower spectrum agents. Continue and document the next review date or stop date. Specify the criteria for stopping antibiotics and keep the course as short as possible. Outpatient parenteral antibiotic therapy, where the patient is able to receive an intravenous or intramuscular antibiotic outside the hospital care setting. Ensure that the updated plan is documented to support continuity of care. Prolonged courses of IV antibiotics should be avoided to reduce the risk of line infection and bacteremia, the incidence of thrombophlebitis, demand on nursing time, waste by switching to less expensive oral antibiotics, the risk of serious error such as dose calculation and wrong route errors. There are certain situations where it is appropriate to continue IV antibiotics, such as patients in ITU or HDU, certain deep-seated infections such as abscesses or bone or joint infection. The capacity to swallow or absorb oral antibiotics is reduced. When patients are being discharged, they should be told what to do if their symptoms are getting worse or changing. Red flags should be highlighted that indicate urgent medical attention, such as a severe headache, chest pain, or coughing blood. Encourage antibiotics to be taken as prescribed, not saved for later or shared with others. Start antimicrobial treatment promptly in cases of sepsis to reduce mortality. Preserve the effectiveness of broad-spectrum antimicrobials by limiting their use to patients at risk of resistance to first-line agents or for patients with severe or life-threatening infection. Take appropriate specimens for culture before starting antimicrobials if possible to guide management. Check for allergies, contraindications and interactions before prescribing. Avoid prolonged courses of IV antibiotics. Support patients with safety netting advice on discharge. There are a number of resources which can provide further information. These can be accessed through e-learning for healthcare and include helpful resources such as the Antibiotic Review Kit and the Health Education England's AMR Toolkit.